Okay, dear students, today we will talk about cough and expectoration. So, first of all, what is cough? A cough is a sudden explosive forcing of air through the glottis. Why? Because to expel mucus and other materials from the tracheobronchial tree. So, defense reflex that enhances the clearance of secretions and particles from the airway and protect the lower airway from inspiration of foreign material. So cup is simply is what? It is a protective mechanism that helps you to clear your airway. Okay, some foreign bodies or anything. So it's a sudden explosive forcing of air. So how we do that? Let's see in the next slide. Coughing may be initiated either voluntary or reflexively. Okay, so we can initiate this cough. Even, for example, a doctor sometimes asks you to cough for him, and then you can cough because it can be voluntary, right? And then sometimes it's sudden reflex, and you just cough. It's like you have not done it by yourself. It is the most pathognomonic of all respiratory system symptoms, and it is expression of disease in upper respiratory passage, the bronchi or lungs. So if this is a continuous cough, so it is the pathological symptom that can clue to some, respiratory disease. Now, cough reflex, how it is formed, let's see its mechanism. Cough reflex initiated by chemical mechanical stimuli. Okay, so it can be chemical, it can be mechanical stimuli. So what happened actually? This is carried out by these stimuli are carried by afferents, which are type C or type 1 fibers. Then innervate pharynx, larynx, large airways, terminal bronchiole, and lungs parenchyma. So then these afferents, they travel via vagus and superior laryngeal nerve to the brain stem, where there are the cough centers. And then there are some efferents. They also travel via vagus, phrenic, and spinal motor nerve to the larynx, tracheo, bronchi, and then they reach to the bronchi, to these area, and then they cause the diaphragm to produce the cough. So this is the first mechanism. We saw which nerve and where they innervate. In the next slide, I will show you how diaphragm produce cough. So mechanism of cough reflex. Here you can see the cough starts with the deep inspiration. So in the first picture is the irritation, and then after the irritation you take a deep breath, followed by glottis closure, and then you close the glottis. After that, what you do is the relaxation of the diaphragm. So you see here the diaphragm is get, this diaphragm, and then it get relaxed, and muscle contraction again are closed. So when the glottis, you see it was open when you were inspiration, then you closed it, you relax the diaphragm. When you push that time the diaphragm hard, you will just produce a sound that we call is a cough, and it will eliminate this increased pressure that you have created the air and things are out, right, from your respiratory tract. This is called cough. So you see this is the cough mechanism. You close the glottis and you suddenly push the air against it. So etiology of the cough, there are an exogenous source, endogenous source. Like exogenous source can be smoke, dust, fumes, and foreign bodies, and some outside of the body, right? And then some endogenous origin like upper airway secretions and gastric contents. And then any disorder resulting in inflammation, constriction, infiltration, or compression of the airway can be associated with the cough. Asthma is a common cause of the cough, you should be remembering. And in a known smoker, the most common cause of chronic cough are hoarse, nasal drip, asthma, and gastroesophageal reflux that we will be discussing in next slides. So next thing you should be knowing about the cough. Now you know what is cough, what is the mechanism. The next thing you should be knowing what is the classification of the cough, right? Acute cough is maximum of 3 weeks. Subacute cough is from 3 to 8 weeks, and chronic cough more than 8 weeks. Etiology of the cough, like some common etiologies or diseases of acute cough is normal, the upper respiratory infections like colds, common cold, acute bacterial sinusitis and pertussis, pneumonia, pulmonary embolus, and then congestive cardiac failure. So they can be acute causes of the cough. And subacute is the post-infection, post-nasal drip following viral infection, pertussis, some tuberculosis infection, and mycoplasma or chlamydial infection. And then some chronic cough is like, asthma, COPD, tuberculosis, some carcinoma, syphilitic bronchitis, esophageal disease, and post-nasal drip, ACI, angiotensin converting enzymes, and then smoking. Common causes of chronic cough, common causes that you will see in the clinic is upper airway cough syndrome, 38 to 87%, asthma, 14 to 43%, GERD 10 to 40%, and chronic bronchitis is 0 to 12%. And more than one cause is 22, 24 to 72%. So now first thing, upper airway cough syndrome, also called post-nasal drip syndrome. Okay. Most common cause of chronic cough in all age groups. Second most common cause in children, and most common cause in adults and adults, right? In addition to the cough, this can also present with wheeze and dizziness. So how you will know that upper airway cough syndrome? There are some clues to it, right? So these patients frequently clear their throat, right? And then also this can be noticed by other people. And then sensation of dripping, like something is falling into the throat, and some nasal symptoms. And then if you do the physical examination, you will know the secretion in nose and oropharynx, and then cobblestone appearance of mucosa, right? So these are the clues that can tell you upper airway cough syndrome. Chronic cough more than 8 weeks, we can see in asthma. So what is asthma? It's a chronic inflammatory disease of the airway, and then characterized by increased responsiveness to the tracheobronchitis to many stimuli, right? And physiological, there is a reversible narrowing of the bronchi, and clinically there are paroxysms of wheezing, cough, and dyspnea that you can see in the cough variant asthma. 36% of patients presenting with chronic cough that was due to asthma had cough as their only symptom, right? For example, clues for this kind of cough variant asthma will be nocturnal cough, exercise-induced, or after allergen exposure. And then in this you can do is a bronchoprovocation test that will be positive. But negative test exclude asthma, but does not rule out the steroid responsive cough. So this point should be kept in mind. Sometimes the antihypertensive therapy like ACE inhibitors, they can produce like enalapril, captopril, lisinopril. They can produce dry cough in 3 to 30% of patients. So this mostly starts within 1 week or to 6 months after the drug started, right? So drug history here is also really important. Usually resolve 1 to 7 days after stopping the therapy, but can take 4 weeks. Diagnosis is confirmed when cough disappears after drug is discontinued. So this kind of cough, it is started after the angiotensin converting enzyme therapy, and you ask the patient whether he's used this therapy or not. Mostly this kind of cough is a dry cough. So in chronic cough, other cause you can see here is a gastroesophageal reflux disease, GERD. Okay. So there are two mechanisms, micro and macro aspiration of esophageal content into tracheobronchial tree. And of course, when there's some aspiration of these micro and macro things in the tracheobronchial tree, they will irritate this respiratory tract and cough production will occur. And then acid in the distal esophagus. Again, if we remember initially we have talked about some, mechanisms in the beginning. So if you here the stimulation of vagal in this area, then can also mediated esophageal tracheobronchial cough reflex will occur. Less common causes of common chronic cough. So these all like bronchiectasis, C inhibitor, post-infection, occult inspiration, lung cancer, cult CHF, chronic heart failure, and interstitial pulmonary fibrosis, and then is atypical mycobacterial infection and fog bodies. Here you can see industrial bronchitis, nasal polyps, problem with the auditory canal, larynx, diaphragm, pleura, pericarditis, and esophagus. As we know in this, that when we have talked about mechanism, their receptors are present that can initiate the cough and some psychogenic cough. So how we will approach the patient? You can ask a detailed history, physical examination, chest radiograph, pulmonary function test, gross and microscopic examination of sputum. You will go for CT scan and fiber optic broncho. Okay, investigations. You will go for spirometry, demonstrate significant airway reversibility, and then also the bronchoprovocation test. We have already talked about it. Is negative. If it is negative, it does rules out asthma, but does not rule out steroid responsive cough, right? And then plain sinus radiography, low specificity, but improves with history and findings. And then sputum eosinophilia, any infections or allergy, it will rule out that. So take home message, in patient with chronic cough with a normal X-ray finding who are non-smoker and not receiving therapy with the ACE inhibitor, the diagnostic approach should focus on detection and treatment of upper airway cough syndrome, formerly called postnasal drip syndrome, asthma or GERD along in combination. This approach is most likely to result in a high rate of success in achieving cough resolution. So if you see a patient is non-smoker, right, and he's not taking ACE inhibitors and some this kind of things, and so you should be thinking about like GERD or postnasal drip syndromes, and then you should find the clues, and then this can be really helpful in treatment.